Welcome everyone, thank you for joining us. We are now going to start today's webinar. Before we begin, I'd like to go over a few details for today's webinar. To ensure audio quality for all attendees, we have muted everyone's lines. That means that you can hear us, but we cannot hear you. Even though your lines are muted, we want to hear your questions. To ask a question, use the chat feature that is on the right-hand side of your screen. You may have to click the arrow next to it to expand the section. We will answer questions at the end after all of the presentations are finished. And with that, I'll turn it over to Dr. Amy Eden, who will kick us off. And Dr. Eden, you're muted.
I swear I hit the button. All right. Good afternoon, everyone. My name is Amy Eden, now that you can hear me, and I'm the Acting Director for AHRQ's National Center for Excellence in Primary Care Research, or NCEPCR. It's my pleasure to welcome you to today's webinar. Can you go to the next slide? For those of you who might not yet be familiar with NCEPCR, our mission is to support transformative primary care research, tools and methods for implementation, and the next generation of primary care researchers, all to improve the delivery of primary care. You can learn more about NCEPCR on our website, where you can also access tools and resources and research and see the ways in which we're supporting primary care research and researchers. Next slide. Last month, NCEPCR released a report documenting AHRQ's investments in primary care research, focusing on projects that were active in 2021 or 2022. This report is available on our website, and I encourage you to check it out if you haven't seen it yet. Next slide. This graph is from that report, and I just wanted to show it so that you can see the main areas of primary care research that AHRQ has recently funded. Of the 124 investigator-initiated primary care research projects that were active in 2021 or 2022, you can see that almost 30% had a focus on person-centered care. And indeed, one of AHRQ's 3 main research priority areas is research on the delivery of person-centered whole healthcare, which we know is critical to optimize health, functional status, and well-being, as well as to eliminate health inequities across the life course. Next slide. And just quickly wanted to highlight our 2 primary care specific funding opportunities, both of which welcome applications that take a person-centered care approach or look at person-centered outcomes. Next slide. So today's webinar highlights 3 research projects that involve person-centered tools and processes that support primary care practice. These projects span from developing a measure to testing care planning approach to an implementation study, all with a person-centered focus. And they'll be presented by an esteemed group of investigators from diverse disciplinary backgrounds. And now, next slide, I'd like to introduce our moderator for today's webinar, my AHRQ colleague, Maya Gerstein, who is a health scientist in the Division of Practice Improvement, where she leads a portfolio in shared decision-making and health literacy. She'll introduce our presenters and facilitate the Q&A and discussion, which again will take place after all of the presentations are finished. Thank you so much, Maya. Welcome, and over to you.
Thank you, Amy, for the introduction and the invitation to moderate today. I want to just take a few moments to introduce our presenters, and then I will turn it over to them. As Amy mentioned, we have 3 primary care researchers with us here today. Each of our presenters is going to be discussing their research on person-centered care. So you can join me in welcoming first Dr. Ian Hargraves from Mayo Clinic in Rochester, Minnesota. He's going to be sharing with us his work on the development of a new measure for the occurrence of shared decision-making in the care of patients with chronic conditions. Dr. Hargraves will be followed by Dr. Alex Krist from the Virginia Commonwealth University School of Medicine. He's going to be sharing with us his work on using risk measurement to help clinicians and patients create care plans and set goals together. And then finally, we will hear from Dr. Zsolt Nagykáldi from the University of Oklahoma College of Medicine, who will be sharing with us his work on improving person-centered care practice for non-cancer related pain management. Before I hand it over to them, just want to mention to please be sure to save your questions. We will have time for Q&A after all the presentations are over. You can also feel free to pop your questions into the chat throughout the webinar. Someone will be monitoring the chat and we can bring your questions forward to our presenters during the Q&A. So with that, I'd like to turn it over to our first presenter, Dr. Ian Hargraves.
Hello, everyone, and thank you, Mayo and AHRQ for the opportunity to talk with you today. My name is Ian Hargraves. I'm a shared decision-making researcher based at the Mayo Clinic in Rochester, Minnesota, and I'm going to be talking a little bit about shared decision-making in the context of chronic care. Next slide, please. So shared decision-making accounts of it vary, but common themes in descriptions of the process of shared decision-making are that it follows steps of the clinician declaring that a decision needs to be made and there are choices, inviting the patient to participate in considering those choices, providing the necessary information about the options, and together with the patient weighing the pros and cons of those particular options against patient preferences. Next slide, please. There's a number of very good reasons for promoting shared decision-making in the context of chronic care and person-centered care. One argument that's been advanced is that the idea that if we make better decisions in healthcare, we will achieve better outcomes for our patients. And shared decision-making is a way of reaching better decisions and help and eventually better things for our patients down the road. Next slide, please. Now, you may have noticed in that previous picture of Maria Luisa, she had a lot of healthcare sitting on her kitchen table. 10 or so medicines, all the result of decisions, some of which may have been shared decisions, I don't know. But the actual decisions that made a big difference in Maria Luisa's life, where we saw her sitting somewhat dispirited in her kitchen, didn't happen through a process of shared decision-making that follows the traditional pattern of a clinician trying to involve a patient in weighing the pros and cons of a set of options. What did make a difference was when her granddaughter, Anna, who is an MD, visited, saw the nature of Maria Luisa's situation, and together they worked through ways that they might make it better. So things changed when they figured out that if a stairlift was installed, then Maria Luisa wouldn't be isolated from the rest of her family in her downstairs apartment. They also worked through that if they shifted Maria Luisa's dialysis to the evening rather than the morning, then she wouldn't be exhausted after dialysis and not able to participate in family activities. And also that the staff on the evening shift at the dialysis center spoke her natural Spanish, and so she was much more comfortable there. Along similar lines, they also were able to adjust her diet so that she could meet her dietary requirements at the same time enjoying food from her native Peru and the flavors that go with it, bringing her, restoring some joy back to eating in her life. So problem solving, not weighing predetermined options. In both cases, shared decision-making is happening, but in different ways. Next slide. And because decision-making, this sort of decision-making where involving sorting through problems and trying to figure out how to make things work is quite common in primary care. In fact, our work looking at video encounters of diabetes consultations found that this problem-solving activity occurred as frequently pros and cons as forms of shared decision-making. We also, in other work, found that the current observer measures of shared decision-making do not detect the use of problem solving, which is forms of shared decision-making, which are often appropriate to the kinds of problems that primary care clinicians are helping their patients with. Next slide, please. And so in the context of shared decision-making in chronic care, it's perhaps worth reconsidering what we define shared decision-making to be. And so we are following the idea that it's helpful to understand shared decision-making in this context is occurring when patients and clinicians work together to change a problematic situation, the bread and butter of medicine. Next slide, please. Now, following the earlier argument, we are looking at the proposition, well, if we help patients and clinicians work together to change problematic situations, better outcomes may follow. One challenge in pursuing this line of thought and trying to advance it is that we don't currently have the means to determine if in an encounter, patients and clinicians are doing this. Next slide, please. And so this project that I'm presenting today, an AHRQ R01, is intended to develop a theory-based observer measure of shared decision-making that would allow an observer to answer a very fundamental question. In this encounter, are a patient and clinician actually working together to improve a problematic situation? As you can see in this triangle, there's three corners to it. Crucial elements are working together, tackling problems, and making progress in doing so. Next slide, please. Its basis in theory rests on the work of the pragmatist philosopher John Dewey and his account of inquiry, and particularly conversational inquiry. In this context, it's a process of noticing problems, trying to understand what they are, trying to come up with ideas for changing things, testing them out, trying them on, experimenting them in our minds to see if we can make them work, and then pulling it together in a course of action. Some things that are particularly distinctive about this approach, and perhaps a little different, is that it focuses, the way it understands a problematic situation is that there is some sort of emotional content to it. There is no problematic situation if nobody cares about what's happening. And so emotion is an important component. Another important element in this line of thinking is that actually talking things through changes the situation you're dealing with. So as you talk through possibilities like a steal-if emerge, what seemed to be a beneficial idea of going to dialysis in the morning became apparent that that wasn't actually as beneficial as it was thought. In the conversation, the nature of the situation is actually changing. Next slide, please. And so this measure that we're developing, to give you a little sense of what it is and how it works, it allows an observer to review frequently a video recording of a patient-clinician encounter. It will have a set of sensitizing items. So these are things that the observer could be looking for that are associated with people working together to advance problems. And the use of those items and observing the encounter, at the end, they're in a position, the observer, to make an informed global assessment of the occurrence of shared decision-making, to be able to answer the question, did these participants work together to improve a problematic situation? Next slide, please. And so throughout the three aims of the project, we're following a user-centered design approach. In aim one, this is used to develop an initial set of potential theory-based observable actions at the sensitizing items that I described that may indicate SDM, and to narrow those down from a large set into a small one that we can bring forward for field testing and iterative refinement. And then finally, after the conclusion of that refinement and about that phase, we're going to proceed to produce an estimate of the reliability and the validity of the SDMo instrument. Next slide, please. So briefly, in aim 1, the goal is to produce the initial instrument. And so from a design research point of view, we're trying to draw from inspiration from lots of different sources. So we've been observing encounters to pull out activities that are happening when we see people grappling with problems, looking at the literature, not just the medical literature, but the literature from many other disciplines as well, which tackle analogous situations, learning from existing observer measures, the brainstorming, trying things out against videos of encounter, and concluding in a process of bringing the narrow set from a big set of ideas to a narrow set that we can move forward to a Delphi panel for review to select the ones that will go on to the next phase. And we'll also bring those to conversations with patients and clinicians as well. Next slide, please. And so once we have this first draft of the SDMo instrument, then we're going to go through a process of refining that, and where we're going to bring in a set of novice users, unlike the research team who is pretty familiar with the instrument at this point, to actually try using this instrument to rate video recordings of different encounters. And through this process, what we learn as people try to use this, we will iteratively refine the tool further and further so that we think that it's actually capturing what's important and people are able to use it and make the judgments that it requires. Next slide, please. In aim 3, where we work to estimate the reliability and validity of the, at this point, complete instrument, we're estimating the reliability by again, bringing in 6 novice users of the instrument, having them watch different videos of different encounters, and then we're going to compare the way that those different users score those encounters to get a sense of how much agreement there is across novice users. In order to establish an indication of the validity of the tool, we've set forth 3 validity hypotheses. That the first one is that there should be some sort of correlation between the SDMo instrument and the option 12 instrument, which is the predominant observer measure of shared decision making currently. And so we are going to have users be looking at videos that were previously scored in trials, and for which we have their option scores, and compare what happens with SDMo with that. And we hypothesize that we would expect a correlation of somewhere between 0.3 and 0.5. There's a relationship because whilst they're not looking for the same thing, the things that they are looking for are in some way related. Similarly, same process with the decisional conflict score. And finally, we are hypothesizing that that shared decision making, SDMo is able to detect and increase performance of shared decision making in the presence of a decision aid within the encounter. Next slide, please. And so where we are with our findings. So in aim 1, we've generated about 1,300 potential sensitizing items that could be used, and we've reduced that to a set of 40, which is going to the Delphi panel. We found that the theory that lies behind SDMo is used in several non-medical disciplines. It occasionally arises in the medical literature, but when it's in the medical literature, it's not presented in its collaborative or conversational form. We've also found that this approach is novel in the shared decision-making literature, and we're also finding that it's possible to shift the evaluation of shared decision-making away from what individual actors are doing to the presence of a method of figuring out what to do in response to problems. In aim 2, to support aim 2, we have developed a custom web-based interface that we can use for the prototyping phase, where our novice users can click on these sensitizing items through while they're looking at the encounters, and through this process of engaging with them, eventually reached a conclusion as to the presence of SDMo. Next slide, please. So in terms of lessons learned, we have found that the sort of novel theoretical and practical approach that we're taking is very time intensive to realize. And a lot of the reasons for that is that the right language to get at what we want novice users to be able to detect isn't well developed. And so we're having to create the language and help people provide the orientation to what it is that we're hoping that they are able to see. There's also the issue of balancing the depth of the theory with the actual ability of people to use that constructively. And so there's sort of a sweet spot there. We've also found that it's important to have the right team balance. So particularly in our case, the presence of sort of mid-level researchers who have content expertise in the domain and are able to help lead the more junior researchers throughout the process. Next slide, please. And then I'll just wrap it up with these are the references to our work and other people's work that relates to this presentation. Thank you.
Thank you so much, Dr. Hargraves. I look forward to engaging with you a little bit more about this project during Q&A. Next, we have a presentation by Dr. Alex Krist on patient preferences in addressing health behaviors, mental health, and social needs. Welcome, Dr. Krist.
Thanks, Maya. And I really love Dr. Hargraves' approach of thinking much more about the method of decision making and not just the behaviors. And as a family physician, that resonates with me and what I do with my patients every day. So I'm excited to see the instrument that comes out of all their hard work. I'm going to talk a little bit now about outcomes of decision making processes, very specifically the choices that patients make, collaborating with navigators in deciding about what health behaviors, mental health, and social needs they'd like to address. And the work that I'm going to talk about today is really the work of our whole team. It's our practice-based research network team, the Virginia Ambulatory Care Outcomes Research Network. A lot of folks are putting a lot of hard work on this, and we've got a website and links to all the materials at the end. So I get to talk about the patient centeredness and the decision-making process, but most everyone else is doing all the real work. Next slide. So we know that health behaviors, mental health, and social needs are primary drivers of health outcomes and well-being for people. And they contribute so much more than the conventional biomedical things that we do to patients in these different outcomes. And we try to focus, and we believe that addressing these poor causes of poor health are really important. And yet it's really hard to do this in practice. So a central focus of the study that we're trying to think about is really how do we create a feasible mechanism to help people improve their health behaviors and their mental health risks and address their social needs. And we're linking it to multiple chronic conditions and trying to say, would this be a better pathway for improving control of chronic conditions and maybe even in the future preventing chronic conditions from even developing for people? Next slide. There are dozens of recommendations about screening and counseling people for diet, for exercise, obesity, alcohol use, drug use, social needs, depression, anxiety, lots of talk about loneliness and other factors that contribute to our quality of life and contribute to our physical health as well. You've probably read the research that looks at how many hours a day would a primary care clinician spend to implement the U.S. Preventive Services Task Force recommendations for a panel of 2,000 patients, and it's about 8.6 hours per day. The biggest contributor of delivering the preventive services from the task force, it is addressing these root causes of poor health. It is the health behavior change the mental health, the substance use counseling and screening. So having feasible ways to address these are extremely important. Next slide. So as I said, our goal in this study was to test a feasible, patient-centered, enhanced care planning approach to address these root causes of poor health, and to compare whether it's more effective than the conventional biomedical care that's usually occurring. And as part of our aims, we were looking at the reach and the implementation of this care planning approach, and then we're comparing the effectiveness. Does this improve control of these chronic conditions compared to conventional biomedical care? Does it do a better job of this? And then we're trying to look at the patient, the practice, and the community contextual factors that influence these different outcomes. Next slide. This is a 5-year AHRQ R01, and we're now in year 5 of 6. So we started in 2019. And you can imagine we developed our instrument and our intervention, our approach, and started fielding it in 2020. So that's a little bit of a contextual factor on our results, trying to deal with COVID as we're doing this. And in theory, COVID would make all of this much more important to address than in non-COVID times. And it's a clinician-level randomized trial in our ACORN network, and we focused on 3 regions of practices: Richmond, Fredericksburg, Charlottesville, and Fairfax. Actually, 4 regions, sorry, spoke wrong there. And it was clinician level, so we wanted clinicians to continue what they usually did with all their patients, or really try to do this enhanced care planning, have that offered to their patients. And I'll show you in a second, most of the enhanced care planning was done by different team members and not the clinician, him or herself. And all patients with multiple chronic conditions, one of which was uncontrolled, in that patient's panel were invited to participate with a goal of us recruiting 10 patients per clinician. Next slide. So here's the intervention, and it had 4 components. I've got the number right. I know there's 3 diagrams here, but there are 4 components for this one. The first one was this My Own Health report, which systematically walked patients through and did a health risk assessment on 19 different domains of health, behavior, mental health, and social needs. And then it showed patients how they did on these different things and what factors might put them at risk for poor health. And it asked them which 1 or 2 they might want to work on to create a care plan. And then it walked them through the steps of creating a care plan that included things like describing a narrative of, have you ever tried to address this before? And what happened? And what are your barriers? And what do you think would make this feasible? And then it showed patients different evidence-based strategies that they could select from that might help them to address it. And then it showed them their plan and asked them to kind of think about how confident they were on achieving that plan. And if they scored low on a confidence, it suggested that they might want to adapt or modify their plan. That was the My Own Health report tool, and then it also allowed them weekly to go back in and update their progress and their confidence, and to change and modify their plan. They could create or complete a care plan, saying they finished it, and then create a new care plan if they wanted. The second and third parts of our intervention was connecting people with a patient navigator and a community health worker. So the patient navigator was from day 1, and patients who didn't feel comfortable with going into My Own Health report and completing it themselves, the navigator helped them and did it for them. So this was a collaborative process and very much a shared decision-making process of, showing a person what their risks were, and then the navigator helping walking them through creating the care plan. And talking about, were they doing the right care plans, and were they the ones that mattered most to them? And if the patient did the My Own Health report on their own, the navigator would get the report and then go back and have those conversations with patients and help them modify things. And then some patients were linked with community health workers. If the navigator and patient thought that there were community programs that might help them achieve their goals, and that community health worker knew about all the resources in the 4 different communities we were working with, and then that was the 4th component, we would link people to community programs and try to connect their medical team and their community care teams together to help them achieve their care plans. Next slide. Here are the 19 topics that the risk assessment addressed. So, there's a number of health behaviors, everything from diet, exercise, smoking, drinking, and drug use. There's depression, anxiety, loneliness, poor sleep. and then social needs such as financial needs, employment, food security, transportation, housing, dental, and home and neighborhood violence exposure. Next slide. And the methods were that we included all patients over the age of 18. They had to have 2 or more uncontrolled chronic conditions. We focused on cardiovascular disease, hypertension, hyperlipidemia, diabetes, obesity, and depression, because we could create outcomes that we could measure around these chronic conditions that we could measure from the EMR and patient surveys to see if they moved from an uncontrolled to a controlled state of being. And we used the electronic health report record and the My Own Health report database, and then patient surveys to measure our outcomes. Next slide. So here are the participants that we ended up recruiting. We recruited 81 clinicians from 30 practices in the 4 regions, and then we recruited 457 patients. And as I said, we reached out to everyone with uncontrolled multiple chronic conditions and happened to have 187 intervention patients and 270 control patients. Next slide. I'm going to focus now on the intervention patients because they're the ones that completed the care plans. And the first thing that we found is that among these 187 people, they had 580 unhealthy behaviors, 240 mental health risks, and 205 social risks. On average, people had 5.3 risks, and there was no one in the sample that had no unhealthy behaviors, mental health risks, or social needs. So this really highlights how important these are and how much we need to address these as part of helping people with preventing and controlling multiple chronic conditions. Now, underneath what you see is the health behavior care plans that people created. 236 health behavior care plans, 29 mental health, and 12 social care plans. And you can see the frequency distribution of each of these in the graphs below. And what might be jumping out to you at first is people created a lot of health behavior care plans, but not as many mental health and social care plans. That jumped out to our patient navigators early on in the study. About a third of the way through recruitment, we noted this and encouraged our patient navigators to work with patients to try and encourage them to do mental health and social care plans, whether that was added on to a health behavior or a subsequent care plan. Next slide. Even with that, though, this is what we found is that among patients who had an unhealthy behavior, 92% made a health behavior care plan, and 23% who had a mental health need made a mental health care plan, and 12% of people with a social need made a social care plan. We took a very patient-centered approach and let people pick these themselves. And my assumption is that this is the right distribution of this, that many of the patients who made the social care plans, even though it's only about 10% of people, that these were the right 10% making care plans that should have been. We did find over the course of people's care plans that these very much intermingled. They would jump across, and health behavior needs fed into social needs, fed into mental health needs. And so it wasn't as in the box as I'm presenting here. Next slide. So among the unhealthy behaviors and mental health and social needs, those 19 ones I showed you, pretty much one patient picked at least one of those for every domain, except for food insecurity. No one picked that, and no one picked drug use. But nutrition, sleep, and financial were the most common ones that people pursued. Next slide. So we learned a lot with this. One of the things we learned is it's hard to do research during the pandemic. That's not a surprise. It was a surprise, though, that even if the topic addressed a need that's even more prevalent. So unhealthy behaviors, social needs, mental health got worse during the pandemic, and we leaned into that throughout the study, but it did make this process more difficult. There was the interest in addressing needs and what they actually created a care plan on. That might not be what's most important to affect their health and well-being. It may be. We didn't actually assess that, though, and we don't know the severity of the needs that people had, and we don't really know how well people thought they could accomplish the different needs, and that might have influenced what they pick. But we felt that we do need a cultural change to better integrate mental health and social needs into primary care, that these are very important, the needs are there, and it'll take some time and some trust between patients and care teams to really adopt and address these issues as part of routine care. Overall, I'd also go on to say that our teams kind of moved in our thinking a little bit. Our main outcome is improving these chronic disease markers, like is your blood pressure and A1C better? But as we're hearing stories of patients succeeding in addressing their social need or their mental health, no longer being depressed or now having housing, I'm starting to rethink that just addressing these root causes themselves might be the most important, even if it doesn't change these different control of chronic diseases. Next slide. And if you're interested, you can easily access our ACORN website and our study website. These will be in the presentation materials, and we have a lot of rich information there. Thank you.
Thank you so much, Dr. Krist. So now I'd like to introduce Dr. Zsolt Nagykáldi. He's our last speaker and will be presenting on reducing opioid use incidence in seniors in Oklahoma. Welcome, Dr. Nagykáldi.
Hi, good afternoon. My name is Zsolt Nagykáldi, and I represent a large study team from the University of Oklahoma Health Sciences Center, which is currently conducting a statewide implementation study. Next slide, please. And the title of the study is Reducing Opioid Use Incidence in Seniors in Oklahoma, or RISE-OK. In this talk, I would like to build upon the points made by my colleagues today and showcase an example of implementing patient-centered research in primary care. Next slide, please. A substantial body of research has been published on how to address non-cancer chronic pain, or NCCP, with or without opioid medications in the general population, but much less is known about how to do the same in older populations that typically have more comorbid conditions that may interfere with or even extend the effects of chronic pain, and in which there is a much greater focus on how pain affects one's quality of life and functioning. And we also know that the use of opioids and other medications show a very different pattern in older populations compared to younger ones where we have most of the evidence. So for these reasons, we established a multidisciplinary team to initiate a large AHRQ funded implementation dissemination study in 2020 during the pandemic as well, to develop and test a more sophisticated care delivery model for older NCCP patients. Next slide, please. The RISE-OK study had 4 overarching aims. In the first year, we convened a series of expert and community advisory groups to help us put the study on a firm patient and community-centered foundation, and to develop critical resources that can help our practices implement patient-focused interventions. In particular, we co-created a RISE-OK practice toolkit and an academic detailing guide for our peer clinician educators and study practices. In the second and third years, we conducted a comprehensive and multi-level hybrid implementation effectiveness study that aimed at improving care delivery systems for patient-centered and goal-oriented NCCP care. And I will say more about these levels later. We also created rigorous measurement structures to assess both the quality of our implementation and the effectiveness of the RISE-OK program at the patient, practice, and health system community levels. And finally, we are currently working on data analyses and the dissemination of lessons learned and our resources through academic and community venues. Next slide, please. This slide shows the distribution of our RISE-OK practices in Oklahoma. The yellow dots indicate the practice sites in our larger primary care network that we approached, and the red dots show those practices that actually participated. You see the striking difference between these that underscore the difficulty of finding willing and able sites for a study that addresses a complex health challenge and which requires significant practice involvement. And on the left side, you can see our practice and patient eligibility requirements that were set to cast the widest possible net across the primary care population. Practices that used EHRs and saw at least 20 NCCP patients 60 or older were eligible, whether these patients received opioid therapy or not. And the patient eligibility followed our practice criteria. Any established NCCP patient 60 or older could participate regardless of receiving opioid therapy. Next slide. Let me say just a little bit about our patient population. We managed to enroll 270 patients out of the planned 310 across 31 practices. These participants followed expected population statistics in terms of age, sex, and race, ethnicity that were closely aligned with the mixture of patients who are established presenting to primary care in our state, including over half of our practices that were located in rural populations. Next slide, please. As I mentioned before, our team deployed a carefully designed and multi-level intervention and evaluation approach. We had numerous patient-centered implementation components and outcomes at all three levels of our intervention. For example, we deployed resources for person-tailored pain management plans, patient goal-oriented intervention approaches, pain function interference measures, and personalized diversification of both pharmacological and non-pharmacological therapy. Next slide, please. On this slide, you can see screenshots of our professional peer clinician educator academic detailer or AD guide that we developed collaborating with Alosa Health. This well-designed guide served as a conversation aid that was used in each practice at the project kickoff meeting. The 80 sessions aimed at introducing the topic and to have a respectful conversation with the clinicians and staff about how to contextualize and apply evidence and resources we offered in this particular setting in order to develop a tailored program implementation plan. Next slide, please. And these are 2 pages from the 80 guide. On the left side, I wanted to show the 5 key patient goal-oriented questions that clinicians could ask to refocus pain management conversations from the pain itself to how pain is a barrier to a more enjoyable life and achieving one's health goals. One of the questions was, what do you do on a typical day? This great question elicits a richer understanding of what matters to someone and what their environment really looks like. Clinicians could also ask, what would you like to be able to do that you can't do now? And this touches specifically on pain-related barriers to achieving personal goals. On the right side, I show an example of how we attempted to distill the many variable interventions related to safe prescribing into a visually appealing and effective mental checklist for clinicians using the Do No Harm acronym as a mnemonic. Next slide, please. In the course of the Rise OK project, we realized that the best way to make research patient-centered is to design a patient-centered implementation approach at the practice, health system, and community levels. Since we envision our entire program in a strongly patient goal-oriented paradigm, we thought that we should also work with our practices in a goal-oriented framework. And so we adapted a formally developed practice assessment tool, which you can see here, that aligned 4 high-level practice goal domains with NCCP-specific objectives, strategies, techniques, and even resources that practices could deploy with the help of our practice facilitators to create their own priorities for a tailored implementation plan. Next slide, please. And look what happened when we based our implementation design on the practice's self-prioritized goals. Instead of focusing on the usual NCCP care process targets, such as medication monitoring or refill policies, most practices turn their attention to learning how to capture and address pain function interference and how to operationalize goal-oriented multimodal pain care. I think we can agree that these represent a more sophisticated, more appropriate, and based on what we learned, perhaps even more effective approach. Next slide, please. Another example from our project for leveraging patient-centered data is a pain management goal setting and goal attainment conversation guide. that we initially planned to use in regular care, embedded in care, but due to study limitations, our team used it in separate phone conversations with patients. Starting with the 5 pain goal questions you have seen, which you can see in the red box, patients were led through a standard exercise to select or craft a custom priority goal for themselves. Next slide, please. This exercise also included goal scaling, including where you are now, what you hope to achieve, and how far you can possibly go, and the usual scaling of perceived difficulty and confidence in achieving their goal. And on the right, I show the attainment scaling part of the guide, where barriers are reviewed, an action plan for overcoming them is created, along with self-rating of one's progress. Next slide, please. What's really interesting as an early outcome of this particular approach is that, again, instead of the expected focus on improving pain control, which you can see listed at the red arrow, we find functioning and quality of life goals as the highest priorities that patients set. Even when patients told us that their priority was to receive services, most of the time they aimed at addressing functional capacity and life quality. Next slide, please. In this third and final example from RISE OK, I would like to provide some very early results from 10 patient, 10 clinician, and 5 clinic staff interviews that are being analyzed currently. Patient interviews explored many domains, including the quality and content of primary care conversations, goal setting and changes in pain function interference, care experiences, and changes in the patterns of therapy. What we can say at this point is that emerging themes include functioning and quality of life as the main concern for patients related to pain management. That NCCP in older adults is even more complex and multifaceted than we thought, and that current healthcare is spotty at best in terms of balancing patient and clinical needs to respond to patient needs to improve their quality of life. And some of these themes are substantiated by patient quotes on the right side, reflecting both success stories and some of the shortcomings from the patient's perspective. Next slide, please. And finally, I would like to say a few words about our practice interviews that we just started analyzing. These interviews were very detailed and they covered major steps of the chronic pain management care cycle, in addition to the experience of clinicians and staff participating in RISE OK, and lots of barriers and facilitators to implementing and sustaining the program. In order to underscore the importance of addressing practice resource gaps, I would like to highlight the third quote. This clinician said, "We can be told things all day long, but if you don't have that resource at your fingertips to look back on and things like that, you know it's hard." One of the strengths of our program was to help resource practices through practice facilitation and by co-designing and deploying a large library of resources that were linked to individual practice priorities. Next slide, please. In summary, we have learned about the utmost importance of robust primary care practice and patient support, and building capacity for a patient goal-oriented care approach, which we would believe has great potential to make chronic pain care person-centered. We also learned that substantially more work is needed to provide those integrated data and care systems that can effectively respond to complex needs of older adults with NCCP, and that there are large care gaps in services, especially in rural and underserved areas, to diversify chronic pain therapy. And finally, RISE OK exemplifies how a multidisciplinary and comprehensive approach to NCCP management can move the needle for older adults toward better patient-centered outcomes and care experiences. Thank you for your attention.
Thank you so much, Dr. Nagykáldi. Thank you to all of our presenters. So before I open things up to our Q&A session, I just want to remind everyone how to submit your questions. If you want to ask a question and you haven't already done so, please go ahead and use the chat feature. We'll be monitoring that and can put questions forward to our presenters. We'll answer as many questions as we can. I see that we already have several questions entered into our chat during the presentations. And to get us started, I have a few questions for our presenters as well. So this first question goes to Dr. Hargraves. How do you envision the completed SDMo measure will or can be utilized in research or in practice to bring us closer to our goal of providing true person-centered care?
It's a great question. So I think what it does is it allows us to ask questions, research questions or practice questions that focuses on, are we working with our patients to tackle the problems that are troubling them? Are we actually engaging in the problem-solving work of trying to make a difference? And I think understanding that, whether it's happening or not, allows us to potentially improve it. One of the notable things about that stance is that the vast majority of clinicians are trying to help their patients, particularly in primary care. They're trying to make the most of the situation the patient's in. And so when we introduce shared decision-making in that space, it's not as here's an extra thing that you ought to be doing with your patients. It's much more shared decision-making is a way of trying to amplify what you're already trying to do with your patients. You're already trying to change things. Are there ways to help work with patients to make things better?
Thank you, Dr. Hargraves. This next question is for Dr. Krist. So you touched on this a bit already in your presentation, but I'm wondering what you think contributed to the differences that we saw in patients' interest in creating care plans that addressed health behaviors versus mental health and social needs, and how we might be able to achieve more interest in addressing those types of high impact needs among patients, or even if that should be our goal in providing person-centered care.
Yeah, thanks. I didn't have a chance to touch a lot on this, but some of our preparatory work that we did with patients and clinicians was really exploring what it would take, kind of their confidence levels, and what would it take to do some of these things. We found many patients right at the start were surprised to hear that, oh, my primary care clinician can help me with my social needs. So they really didn't think about that much as the scope of care and practice. Our patients were very kind to clinicians. They actually often said things like that they would only want to talk with their clinician about things like these topics if they felt like their clinician had a team and support and infrastructure to help them do a better job, because they didn't want to just dump that on their doctor, who they tended to trust and rely on. So, we heard very strongly that some of their cultural change comments sort of came out, where people start to realize that this is important. It should be part of the discussion. Not only does it impact health, but it can change outcomes. There's a lot of literature here about negative experiences people have had. There's stigma with having social needs or mental health issues. A lot of them can be self-imposed, but also by society, and reaching out and getting help can be looked on badly. And people talked about discrimination and other factors. So there's a whole range of issues. I think for our future work, I want to look a little more at that. We'd also want to look at how people felt, like how confident they felt they could make a change, and how severe, how much they thought something impacted their health, kind of as a process point for trying to get at what they might want to be focusing on.
Thanks. This is for Dr. Nagykáldi. So you highlighted the importance, specifically in your lessons learned, about the collection of health data that matters to the patient to be able to more effectively address non-cancer chronic pain in a person-centered way. And I think we, as health services researchers, we spend a lot of time focusing on the challenges of collecting patient-centered data and integrating systems and data streams But I'm curious what you think might be some of the most promising avenues or opportunities for more robustly collecting health data that actually matters to the patient.
I think, and I would like to connect a little bit to the comment also about how in the VA system, some of this has been tried and there has been a workload distribution issue. I think we are talking about a paradigm thinking model shift. This, I don't believe, preventive services in general, true prevention, true prospective care does not fit well into the current healthcare approach. And so taking these ideas and trying to squeeze them into the current system is always going to be really problematic. But there are ways and there are models when you look at, especially in the goal-oriented healthcare literature, where there's a culture shift at the organization to realize that upfronting these processes with resources and time, and then let that affect the downstream positive effects is the right way to go, instead of counting beans in terms of minutes and so forth, and not allowing that investment to happen upfront. How many parallels can we draw with research and all of that within this kind of thinking actually makes it worthwhile? And those organizations that invested into that and took the leap and really thought through this were often, not always, but often able to realize the benefits without that kind of issue of what happens with the workload and how do we collect this kind of information. Well, if we deliver this kind of care, this kind of information will be collected in the process of care because that's the right thing to do.
Thank you. I'm going to move on. We've had some wonderful questions come in here from the audience. And so I want to make sure that we get to those, at least a few of those. We had one for you, Dr. Hargraves, about the longitudinal relationship of patients and the clinicians. The question was that the observer for the SDMo measure might only be seeing one part of the SDM conversation. So, for example, a conversation might be continued from a prior visit rather than them seeing the whole arc of the decision making. So the question here, I guess, is will or how can the instrument be used to capture these more longitudinal SDM interactions?
So again, a very good question, and I think it's an area of promise for SDMo going forward. You're quite right. This issue of the longitudinal nature of chronic care and its intersection with what episodic encounters is an issue in shared decision-making practice and research. If we focus on particular decisions, then we're looking at this point of time, what decisions were made and was the patient involved in it. And then we can look at the next one, look at the next set of decisions and focus there, very episodic. But if SDMo is taking the stance that what's happening in each of those encounters is two people working together to try and make the most of the situation they're in. And that situation is continuous to some extent. And so shared decision-making, SDMo, for example, with its focus on being able to detect grappling with problems, will help potentially and be able to say, in this encounter, are we actually picking up the problems that we were working on last time, see how they are today, and continuing that work of trying to make things better. So in that sense, what's longitudinal is the endeavor to try and make things better for the patient. The coming together of patient and clinician in a visit is joining that particular effort to make things better, and that's a continuing joining over time. So we think SDMo can potentially look for people picking up ongoing efforts and continuing them within an individual encounter.
While we're on that thread with you, Dr. Hargraves, I wanted to also ask if the measure that you're developing is going to be applicable to what we know can be a really wide range of care team structures, right? Depending on the practice and the institution. So if there's a community health worker or case manager that assisted with that discussion, if this instrument is going to be sort of sensitive to those various team compositions.
Absolutely. So in the interest of this presentation, I talked about a patient and clinician working together. Really, its focus is, are two people working together to try and make a difference? And in healthcare, all sorts of people work with patients in order to try and make a difference. That could be a community health worker, it could be a social worker, it could be just the family themselves. Are people coming together and trying to tackle the real problems that people are experiencing and making problems? And so in that general framing, it's applicable to any effort to work with a patient to try and improve the situation.
Thank you. So Dr. Nagykáldi, we actually got a comment in the chat that I'm going to rearrange a bit into a question, but the comment was, is it too much to expect primary care practitioners to know other ways to manage chronic conditions other than increasing drug levels and instead of getting to like the true root cause of the conditions? And I really think this can reflect, you know, the frustrations that patients feel when they're obtaining primary care or other, you know, services in our health system. And so I'm curious about what are the challenges of managing pain in a person-centered way in primary care that really drove you to build the project that you've built here?
Yes, the question is a little bit hard to answer because I'm not a physician, so not a clinician, so I wouldn't be able to respond truthfully that way. But in general, I think yes, that is the aim of primary care family medicine, to be way more than just a pharmacological therapy, certainly. But I think this is why we, in this process, really emphasize the entire team, and for the team to be multidisciplinary, even going beyond the walls of the practice. So if particular expertise is what's not available in one particular practice, there are some models, and it's very highly dependent on the health system or whether it's a standalone practice, but there are models to pool resources and work together with the community. That's very importantly. Even in our rural communities that have very limited resources, there are often certain ways to at least respond to the needs. For example, how do we access those non-pharmacological therapy options, and then bring that together into the office? Since the clinician may not refer because they may think, well, I have no options. Well, if we are able to either establish or at least highlight that available option and bring that into the practice and create those linkages that could be there, but they were not there, it's community level work and engagement, those things already can help move the needle.
Thank you. So Dr. Krist, you've been engaging a little bit in the chat with some of the questions that were asked, but I think it would be beneficial to the entire audience if I can ask this question to you out loud, and maybe you can talk about it a bit. A question came in of how did clinicians review the patient survey findings, and were they integrated back into the EMR? And if not, what kind of barrier did this put on implementation?
Yeah, happy to answer that. I'm actually going to take advantage of being able to speak and add to what Zsolt was just talking about around the, you know, should these things be integrated into primary care? And, you know, as a primary care physician, I mean, I'll tell you, it's very frustrating when I know and I can see my patients have these problems and I can't help them with it. And I know it's contributing to their health. And I think a lot of clinicians feel that way. We did a study where we had our clinicians a decade ago ask people about their social needs. And then after the visit, we asked them to write down what happened during the visit. What did they think about it? And it was interesting because they expressed on one hand a lot of frustration, like, I found out they were poor, that they didn't have a house, and what can I do to fix that? But then they'd go on to write that they talked to people differently. They gave them different treatments. They set different expectations and had different goals with people. So I think one of the things we're all really learning about is, well, what does it mean to treat these different things? It doesn't necessarily mean we can make them go away. We can't always. But there are a lot of different things that we can do as part of a clinician patient care team, and particularly if you get the whole interprofessional team involved, that can work well. And I did type in a little bit about how we engaged clinicians. We purposely tried to not engage them a whole lot. A, they were stressed and busy during the pandemic, but B, part of our idea was to create a model that could be shared across communities as opposed to like every clinician and every practice recreating these team members. So the idea was, gee, if you could have a navigator and a health worker and kind of some informatics tools that could systematically help people through this, that could be shared resources across communities, could we really start to have a feasible approach that looked realistic? The clinicians were able to log into the My Own Health Report at any point in time and see their patients, their progress and their care plans, and even comment and do things on it. They didn't do that very often, and we know from other work they're not going to log into another tool. It was beyond the scope of this project, though, to integrate it into their electronic health record, because those 81 clinicians from 30 practices had all different instances of EMRs. But we did scan the care plans into the clinicians' records as the project went on, and we would send it to them through encrypted emails so that they could see what their patients were working on. And then the care team members, the navigator or health worker, would contact clinicians, particularly if there were big crises and issues that needed to be addressed, and if it was something that really needed to be done collaboratively between the clinician and the navigator and the patient. So we tried to build some of those bridges, but in all honesty, we could have done that better than we did, and learned a lot about how to do that better moving forward.
Thank you. So I actually have a question for all three of you to weigh in on. Want to get your perspective on measuring outcomes in research on person-centered care. And this is something that AHRQ contends with as well. Are we measuring the right thing? Because if we're not measuring the right, if we don't have the right measures, then are we even answering the right questions? And so I'm wondering your perspective, given your experience now in doing person-centered care work. Do we need outcomes of disease control, or are there better or more person-centered outcomes that we ought to be focusing on, or is it some combination of both of these things? And I'll let whoever wants to jump in here to please go ahead and jump in.
Well,
I can jump in. So yes, the outcomes, very tricky question. And so the look to outcomes, so health outcomes, for example, is trying to answer the question, are we making a difference? Did we make a difference when we did this? Did good things happen? And in primary care and chronic conditions, a lot of the good things, if they're going to happen, are going to happen a long time from now. So it's hard to establish in the context of shared decision making, for example, whether a particular encounter had anything to do with an outcome down the road. The approach that we're taking would be able to look for outcomes around the question of, at this point of time, are we actually grappling with the problem that the patient has? And if we can say yes, no, to what extent, then we can say, well, we know that people are grappling. We don't know what the outcomes of that grappling will be for a long time, but at least we know that they are doing the things that are required to make a difference down the road. And so then the point of the question isn't, are we making a difference? The question is, are we helping?
Dr. Krist or Dr. Nagykáldi, anything to add?
go ahead, Chris.
Yeah, I mean, it's such a challenging topic because some of these things can be in conflict, right? Like you can be very patient-centered and maybe have a worse health outcome in a sense. or vice versa. You can have the best health outcome, but you've done something that completely doesn't align with what someone wants, their mission, vision, goals. And that's a little bit where we started to think where maybe the conventional biomedical outcomes we put for our chronic care control might be a little less important. And I firmly believe that it's about a journey, and it's about what's addressing what matters most to people. I think Dr. Hargraves was saying that in a sense. It's are we helping them with what matters most in their life? And I think if we start rethinking about health as much more of a resource to allow you to accomplish your goals and your mission and your vision in your life, that we can think differently about outcomes. And I'll just also close with saying, I think there is no one outcome. I think this is the blind man and the elephant. I think we have to look at many different aspects of this to kind of understand, are we moving in the right direction and really achieving what we're trying to achieve?
Thank you. It made me think as well as you're talking, and not to throw in another wrench into this conversation, but our payment structures don't necessarily incentivize a focus on mission, values, goals. So we have a lot of work to do, not just in the delivery of care, but in the reimbursement of it. So, but Dr. Nagykáldi, I think you were going to jump in here.
And I agree completely that it's not a one size fits all or a metric set, because this is the nature of the different nature of what we're looking at. But imagine if we could have personalized health plans for most everybody, especially those with complex conditions and needing even more so, but basically for everybody, because we have developmental milestones and we have other areas of beginning and end of life. And imagine if we took that plan that is a agreed upon plan and look into how much of that in what way and how it is being worked out and what is being achieved within that plan. It sounds beautiful, but as you mentioned, it would send those who set reimbursement rates to run for the hills, because it would be different for everybody. You cannot standardize that. And hence, I think, the circular issue if we are not able to let go or not able to figure out how to have also at least a great deal of, or a set of non-standardized, personalized goals as the outcome measure of quality of care, I don't think we will make a very, very significant success. So I'm suggesting that maybe we can think how to achieve that.
Thank you. So I'm going to have that be our closing sentiment as we come up on the end of our webinar. But thank you to all of our speakers for this really wonderful discussion, and for everybody who joined us today and asked questions. We really value your participation, and we look forward to hosting more of these webinars. When this webinar closes out, there's going to be a short evaluation poll that will pop up. If you have a moment, please complete it, because AHRQ really appreciates your feedback, and we take it into consideration when we structure these moving forward. So thank you again to everyone, and have a wonderful rest of your afternoon.